Thank you, everyone, for participating today. I think this is going to be a useful exercise, and hopefully everyone will learn a lot. This is John Gale from the Maine Rural Health Research Center and the Flex Monitoring Team.
This is Sarah Contraster from USM.
And Andy Coburn from USM.
And my name is Hanson from USM.
All right, thank you. So this is part of our whole effort to evaluate the innovative projects. So as you know, what we've done is summarized and looked at what all of the states have proposed to do, and we've selected the group of 7 for more in-depth discussion and tracking. So this is part of that exercise. So we've been through the first 2 rounds of collecting data and working through the logic models and sort of really getting ourselves set up, and we appreciate the work that everyone's put in. But the purposes of what we're doing today is to really give all of you an opportunity to learn from one another. I heard when we conducted interviews with the different programs is just how useful it would be to find out what others are doing. So that's really the purpose of today's exercise. It's a presentation of your progress, some of the lessons learned, if you will, and the things that you've experienced, and a chance to share that with your peers and ask questions. But this program and this webinar is really for all of you. So thank you for your participation. So we're going to do presentations for each of the states, 3 states, Hawaii, Oregon, and Nevada. We'll do about a 20-minute presentation on each of their programs. Thanks so much. And Scott, I will turn this over to you.
Okay. Well, I'm Scott Daniels. I'm with the Office of Primary Care and Rural Health in Hawaii, and I'm just going to do a quick overview of our project, which we started a little bit last year, and then we had extra money, so we said that we would support it this year. So as the description, basically to develop and support Project ECHO in Hawaii. So the goals, broadly speaking, were to improve access to specialty care in rural communities, reduce the number of referrals out of communities, reduce the number of off-island flights for specialty care referrals, and to reduce provider burnout. One of the things that in sort of doing this, we sort of worked with the New Mexico ECHO team. The Nevada ECHO team actually was helpful in us in determining what are some of the areas that they tend to have success with. We were thinking of doing something around Hep C, HIV, except we were told that Hep C is exactly what the New Mexico ECHO started around with the advent with new drug treatments out there for Hep C, rather expensive. They are saying that it's probably better to delay on that. So the key components, and basically that we had to find a cohort of true believers among physicians who could serve as the hub and organizers. We needed true believers because we needed people who would work free or cheap, at least at the beginning of this. You know, basically the money that I have is more, it supports stipend for some of the experts. It helps to support some of the CME costs. It helps, and just to keep the project sort of running at sort of more at the upkeep stage. The other thing was a place to house the Project ECHO. Basically, who is going to have the ownership of this? Where were we going to be able to? Places have their medical schools. They sort of house the project. We had some troubles. I think that comes up on a later slide on the problems we had at the medical school. So we needed someone that would be willing to sponsor this to sort of house it. We needed to do the development of the clinics, and we need a promotion out to the rural providers to let them know that this is happening. This is something that they can take advantage of. So here's what the 4 topic areas are. We're currently running 4 different topic areas. Behavioral health and endocrinology were the first 2 that we started off on, and those have been going weekly. They do take breaks, but generally they run weekly. Geriatrics joined later, and they run a monthly clinic, and then an Alzheimer's and dementia clinic, which also runs monthly, came in after they'd seen the behavioral health and endocrinology clinics take off. We've actually had pretty good attendance for the period that we've been measuring. We've had an average overall attendance of 23.7, which is actually the same for behavioral health during the period for this year. Endocrinology has had about 22.5 people per session, geriatrics 11.4, and the Alzheimer's. HADI is the Hawaii Alzheimer's Disease Initiative, but that one has had about 33 people for each session. So far, everything's been going well with the attendance. We haven't had, and it seems like we have good participation on all of our clinics. So the other achievements, outcomes, is we've sort of had increased knowledge about echo, so it is getting out there into the community. We've been approached by others to develop additional clinics, one around pain management, another one we're looking at developing around public health. We've been approached especially for when we started talking to the critical access hospitals about what are some of the echoes they would like to see happen, and so we're looking at, they had mentioned quality improvement and health information technology, EHR, echoes on basically how to better implement, use the data that they get from their EHRs. And one of the things I'd be interested in is sort of combining those and how to use the information from the EHR towards quality improvement. And then another thing, that outcome achievement, we were approached fairly early on if we could include Pacific Basin providers, people from American Samoa, Guam, Kwajalein, Ibo, those places out in the Pacific. And so our big concern came down to, was there the bandwidth? So we worked with Pacific Basin Telehealth Resource Center and the University of Hawaii Telecommunications and Social Informatics group, because they provide a lot of the courses to the for UH to the Pacific Basin, and found out that they did have enough bandwidth. So we generally have participation from the Pacific Basin providers on most of the echoes. The biggest issue with them is that our lunchtime hours turn out to be their breakfast hours. We are thinking of maybe, if we are able to get additional funding, that maybe we'd have some afternoon sessions. Their resources are a lot different from the resources that are available to people in Hawaii. So maybe having something in the afternoon that also is more focused towards the resource availability of what's available in the Pacific Basin. Like I said, that's something that we're looking at for the future. But right now, we have good participation on each of the clinics from the Pacific Basin. So some of the challenges and barriers, as I'd mentioned, JABSOM is the John A. Burns School of Medicine. We thought that would be the perfect place to basically house this. We ran into some problems with JABSOM wanting to take that on, and so it's actually not with them, and instead we are running it through our Rural Health Association. They're the ones that basically handle the upkeep, and other payments go through for everyone. Stable funding's been a challenge, although we have recently been able to get some grant funding from both Kaiser Foundation and HMSA Foundation. HMSA is the Blue Cross Blue Shield organization in Hawaii, so we're finally getting them on board to provide some funding for that. And we think we might have an opportunity in this upcoming year to get the legislature to actually devote a little money towards ECHO. We've had some problems developing and using the survey mechanism. Originally it was technical issues, getting it developed, and then because we had the technical issues, getting people to actually use it and fill out the survey, or the different providers that are providing the hubs using their own different ways of collecting the information. So I think we finally have some of those issues resolved, but it has made it sort of a challenge on getting all the information that we would like. And then the last challenge and barriers is that when you're working with true believers, you get some strong personalities. So some people have just rubbed each other the wrong way, and that's caused a little bit of drama within our ECHO program, but those issues seem to be working themselves out also. So the people that we rely on for implementing this, are the Pacific Basin Telehealth Resource Center, the Pacific Basin Area Health Education Center, University Health Partners of Hawaii, which is associated with JABSOM, the School of Medicine. The University Health Partners of Hawaii actually provide us with several of the hub experts that we need. And then, like I said, the Hawaii State Rural Health Association is sort of where our ECHO currently is housed. Whether it stays that way or not for the foreseeable future, I don't know. I think as ECHO develops and becomes more successful, I think it will eventually migrate over to JABSOM. It's just at the moment, in order to have an ECHO project at all, this is the way that we had to run it. We found running it through the State Rural Health Association helped us get around the brick wall that the School of Medicine was throwing up for us. So some of the partnerships that we've been with has been like I mentioned earlier, HADI, the Hawaii Alzheimer's Disease Initiative, Executive Office on Aging, both of them, the first one for the Alzheimer's and Dementia Clinic, the Executive Office on Aging on the geriatrics. We work with the Hawaii Department of Health. Even though I'm a part of the Department of Health, we've managed to bring in other offices and divisions into basically providing expertise and ideas into developing clinics. And also the Department of Health does provide some money beyond what our office provides for ECHO. Queens Medical Center has actually provided some of the content expertise. Papa'ololokahi is the Native Hawaiian health systems, and they also provide expertise. They've been instrumental in making sure that the word gets out to the rural communities. Most of the Native Hawaiian health clinics are on the outer islands and in rural communities, so they've been instrumental in making sure that the word gets out about ECHO. And then the University Telecommunications and Social Informatics Research Program, and they were instrumental in making sure that we did have the bandwidth to reach out to the Pacific Basin. They've also been instrumental in setting up some of the telecommunications equipment. So the role of the FLEX program has been basically to advocate the ECHO amongst rural providers, so making sure people know that it's out there. I've sort of been the emissary for the critical access hospital needs. What are the things that they would like to see ECHO providing? What are the areas that are useful for them? We do get some participation from the cause on the various clinics, but we don't get all of them. I think part of it is getting them to find the value in clinics that we have there, but also we need to develop clinics that would be more focused towards some of their needs. The early ones were to get the clinics up and running so that we could have participation, and we would meet a rural need. In order for the cause to have better participation, I think we need to actually address some of the things that they're looking for. That's why we're looking at what we can do around quality improvement, DHR, types of things. And then also we've served sort of as a contact point for others that would like to develop ECHO clinics. So a lot of people come to me for ECHO clinics that they'd like to see developed, and then I take it back to the broader team. We're in the process of trying to develop more. We are sort of restricted by that true believer thing, but as we develop, I know that the medical marijuana program wants to be involved in the pain management, so I think that one may be coming off here soon. So that's it. That was just a brief overview, but I'll take questions at the end.
Thank you, Scott. We'll turn it over to the folks from Oregon now. Meredith?
Thanks. So I'm Meredith Guardino. I'm the Director of Field Services, and Rose can introduce herself in a little bit. We're splitting up the presentation. We're starting with the role of FLEX because I think it's important. This project started as something very different, and it started with, there's a little bit of jealousy on my part around what Scott's been able to accomplish, because originally we had applied for this funding under FLEX with a thought that Oregon, the Oregon Health Authority, was really invested in creating their own state ECHO hub. And at that time, they were deep in the process, and they had involved our office, and we really thought it was going forward. And so the original idea was that we were really going to, through FLEX, guarantee that there was a critical access hospital-specific cohort in that state hub. So you can see from this timeline, 2015 to 2016, so the first year of the grant, and for all those people on this call that will be, sympathetic to when things don't go as planned and you're starting to look at carryover, pretty late in that year, the Oregon Health Authority just doesn't pull it together. They don't create the state hub. It's kind of a monthly process where we're hoping and then kind of coming to the reality that it's not going to happen. So very last minute in 2016, they end up funding a psych addiction project Echo Hub through OHSU, which is also where our office is housed. But the problem with that is OHSU, although it didn't start this way, is a health system in Oregon. And there are a lot of critical access hospitals, particularly out east, that do not want to affiliate with the OHSU system. And so there was a problem there for us in terms of the way we had originally applied for the funding under Flex, and that we knew this wasn't going to hit all the critical access hospitals like we hoped. And then, of course, in addition, that it was pretty specific to one echo topic. So at that point, Sarah and I, and probably Scott, we discussed what could we do around kind of changing this order a little bit. And that's where we got into, we're going to redirect the money to hiring a coordinator, which is Rose, and trying to really look at how we could do this in a non-system affiliated way. So without a state hub, it left us with what information were we going to use to kind of inform this project. And so this slide is a sample of one of the things that came out of our annual listening tour, which is when we go to the rural and frontier facilities and have open-ended meetings with them about their challenges each year. And this is simply a map of the endo FTE in Oregon overlaid with the diabetes death rates and the averages per year. And we point this out because it gets to that kind of Project Echo and then where we go with this project. What are the big issues facing Oregon? Currently, they always come down to workforce versus access. And so when we looked at something like this out of the listening tour, and we saw that the critical access hospitals were struggling with, so for example, if you look at this map, there is no specialist anywhere east of, Redmond. It's a pretty huge distance. How could we look at an innovative way for a short-term solution for these problems? So we looked at the listening tour and what was coming out of that. And the other thing we looked at is for the state, we had been the people who had administered the telehealth grants under the CMMI SIM funds for Oregon. This was supposed to be a huge innovation grant process for Oregon. The applicants were asked to apply with their most innovative telehealth projects. And what came back were 67 letters of interest, predominantly from rural and frontier health facilities. It really wasn't about innovation at all. It was about basic implementation, to the point that most of those letters of intent were really just asking for help implementing their EHR. So telehealth innovation was just too far away. So between the listening tour and then kind of the administration of those telehealth grants, we thought we had a good argument for kind of creating a new project. So I think you all are looking at a slide that would show another map, which is OB, GYN specialists, and then the prenatal care rates in Oregon. And again, this is from the listening tour and kind of what was coming out of that. And the point would be that, so we had the listening tour, the telehealth grants, and then we were also hearing on the listening tour things like, without naming any specific hospitals, we just received a really big telehealth grant from X. What should we do with it? So it was pretty clear to us that people were looking at their access issues, but these critical access hospitals, especially the small independents out in rural and frontier Oregon, were struggling with having the staff time to put together a reasonable strategic plan for how to address some of these issues. So what were the goals of the project? So what we ended up talking about and deciding was, could the Office of Rural Health supplement what were these short-term staffing limitations for the hospitals and offer some assistance to do the research on what would be the right strategy. And in doing that strategy around specifically how to improve service access in their areas, could we look at the two goals of telehealth and Project Echo? That was the goal of the project. The way we put that into place under Flex is we used the money to hire Rose. So she is a full-time Project Echo and telehealth coordinator. We used some money to partner with subject matter experts. So one is the Telehealth Alliance of Oregon, which is really the main expert that we relied on for any sort of telehealth information and expertise, because frankly no one in our office has it. And then the second partner was the Oregon Rural Practice-Based Research Network, which is a long name and acronym, but really is the group which at the end of the day, when the state didn't create a statewide hub, a few years later, they finally put out an RFP. It went to this group, ORPRIN, and ORPRIN is now the body that is creating the statewide Project Echo Hub. So we wanted to make sure we were really integrating our work with them, and so we brought in the project lead from that as one of our subject matter experts around Project ECHO. To Scott's terms, she's definitely a true believer. And she was our kind of echo expert versus our telehealth expert. And then the third part of what we used Flex for is we used it to pay for, especially for Rose, for kind of coming in new to echo and telehealth, to get her to New Mexico, to get her into some of the local trainings, and then to get the funding for her to be able to do the assessments we're doing are on site. So I'm just going to explain a little bit what we landed on in terms of what's in an assessment. So there's pretty much 6 core pieces. Number 1 is we go out with a provider and leadership survey. They are really, really quick surveys. The idea there is that we don't want to take up any provider time on site. The surveys ask providers and leaders the same questions for the most part, and it's about what do you identify as the top areas of access, what do you identify as areas you'd be interested in using telehealth to kind of cover those access needs, and then what are areas in which you think Project ECHO and or provider education might be helpful to addressing some of those needs to providing services on site. And then the final piece is we ask them about their top referrals. We then take that information back. We do a basic service area analysis where we're looking at a lot of the hospital visits by zip code. We're looking at demographics. We're looking at their market, and we're trying to see what their top discharges are. We also look at we're trying to do a community provider leadership alignment analysis. So we look at their community health needs assessment, and we look at their vital stats for that service area. And we're doing that so we can show them in our assessment report where are things aligning and where are they not aligning. And Rose will talk more about this, but are the issues that are being identified by the community in the community health needs assessment, or even just simply through mortality data, being recognized by providers and leadership when they talk about the service access priorities, or even where they'd like to implement telehealth or potentially take part in Project ECHO. The assessment includes an IT discussion with usually the IT director. It's to look at what is the infrastructure of the facility, what do they think are their challenges, including things like the EHR. Is that EHR currently interoperable with their referral network, with their other facilities, et cetera? And then we create a report that has recommendations. And a core piece of this is, after this assessment, what do providers and leadership, now that they've seen kind of where they align and where they don't align, what are some priority areas that they would like our office to research for them? And then the optional piece is, assuming they select those priorities, what was offered to the hospitals is Rose is available to you as essentially that workhorse that you don't have amongst your staff right now. So she will do the research for you on potential areas that you're interested in. On the telehealth side, the key piece here is we really were hoping that this would help them do the strategic planning up front so that they weren't just taking whoever came at them with whatever offer. It's happened in a bunch of critical access hospitals. Telestroke is one example where the equipment is sitting in a corner because it was offered to them, they invested in it, but they never ended up using it. On the Project ECHO side, because of this whole thing that went on with the state hub, and Rose will talk about this in a minute, but also because the new state hub is going to be payer-driven and therefore doesn't necessarily represent rural and frontier, we wanted to make sure we were saying, if you are interested in provider education, we will do the work without any promises to see if we can get you into the hubs you're interested in, not necessarily the hubs that are located or being offered in Oregon. With that, I'll turn it over to Rose.
So as Meredith alluded to, we surveyed the total providers and a handful of leaders who chose to be a part of the process, and that was predominantly C-suite and directors. So we were hoping to see where providers and leadership aligned on these top access issue areas. And so you can see to the right here, we asked them about access, and then telehealth interest, and then finally provider education. The idea for asking both leadership and providers was to get really a well-rounded perspective, not just the providers and leaders who generally speak up. We wanted to see what they would be interested in addressing, the access issues with telehealth or Project ECHO. And yeah, now you can actually see the numbers there. Fantastic. So we had 6 providers and 8 leaders here, and then we sort of categorized those based upon percent of interest, and that's what that shading scale up at the top shows. The whole point here was to be able to present this information back to the leadership team to show them where they're on the same page as providers or where they might think differently about addressing some of these access issues. For example, dermatology is a fine example to show where both providers and leaders, so that's going to be 7 members of leadership and 5 providers, of where they have strong alignment on access, and then they also have alignment on where they would be interested in providing this service via telehealth. However, when you get down to Project Echo, you see that it sort of tapers off a little bit. Interestingly enough, if you take a look at addictions, the very top one, they didn't identify this as an access issue, and there wasn't really any interest in Project Echo or telehealth. We all know that addictions, or the crisis that we have around addiction right now is pretty substantial, and so we did find that to be pretty surprising that there wasn't interest in that, and it was identified as a top level of concern by the community through their community health needs assessment. We took the information from the surveys and then boiled it down to present it to leadership, and we started by showing them where they all align on access, and we wanted to present leadership with not only what they thought of access issues being, but really to include the population-identified needs as well. And so, as I previously alluded to a little bit, we kind of developed a community-level perspective by taking information from their community health needs assessment and that service area data, which includes things like, top causes of mortality. And then also included provider-identified top areas of referral. So the idea here was to present the most well-rounded presentation of access issues to start off with, and then to show the alignment as much as possible between community, providers, and leadership. We just expected to see greater alignment between their top referral areas. Cardiology is the only one here being a top area of referral that was also identified as an access issue. The other 2 top areas of referral were orthopedics and behavioral and mental health. And interestingly enough, they weren't identified as access issue areas, and interest in telehealth. A few interesting things showed up when we talked about ECHO. A challenge was that leaders did not feel it was appropriate to select education topics that they were interested in their providers gaining more knowledge around, and so about half of leaders didn't even respond to that question. And in the end, we really got providers just sharing what they would be interested in, and it wasn't even as substantial as we would hoped it would be. And so you can see here we also again included the provider access, leadership, identified access areas, and population, as well as top areas of referral. And providers kind of hit on those top areas in their education, whereas leadership, not as much. So you can see that it does align with some access issues, but not all. The most surprising finding that we had is both of our pilots did not choose to pursue ECHO in the end. Despite their choice not to pursue ECHO, we included in their final report a list of the available ECHOs countrywide based on their identified interest areas. And if they do decide to pursue this later, I'm available with, of course, no promises that they will actually get into a clinic, but I will certainly try to match them with a hub of their interest, regardless of where that hub is located. So our achievements and barriers. The whole process of creating all of our assessment tools was pretty substantial. We originally thought that there were going to be models to work from or resources out there. When it came to the assessment piece, the assessments that had been created around telehealth were really driven to assess organizational capacity, and they just weren't the right assessment tool for the information that we were trying to capture. The first portion of this was really around creating that assessment tool and then the whole process to go about implementing the assessment. A part of developing all of this was streamlining and creating information, which took a lot of research. And the whole goal was to create these resources that we could make available to our critical access hospitals to help them understand telehealth. An example is we created a fact sheet around how telehealth is reimbursed in the state of Oregon. And as you know, that's a pretty complex process and varies from state to state. So I tried to dig deep into, in Oregon, we have 16 coordinated care organizations, which they all have a little bit of flexibility about how they reimburse. So I try to present some information to provide our hospitals on that as well. The two pilot hospitals were extremely critical in how we choose to move forward. It really forced us to realize that the telehealth piece was not as useful as we had hoped and anticipated, and so we're currently reevaluating that component. As I mentioned previously, we were pretty surprised by the lack of interest when it came to ECHO, and we're looking more closely at that and then different ways to present ECHO as an opportunity to our hospitals moving forward to try to get more interest in that and figure out what's going on there. So furthermore, we are a key partner in the development of the new state ECHO hub. And this is helpful because it gives us the opportunity to provide those key decision makers with what our critical access hospitals' interests are when it comes to the topics that they choose for their ECHO clinics. As Meredith mentioned, it is a payer-driven model, and so that does have its limitations when it comes to critical access hospitals actually having a spot in these various ECHO clinics. So with that said, that is actually a challenge when it comes to Project ECHO, is that it is the payer-driven model, and it doesn't necessarily guarantee a spot for our rural facilities. Another challenge is that our critical access hospitals are a bit all over the place, and we were surprised that neither hospital really identified strong Project ECHO or telehealth priorities to move forward. There is really minimum buy-in and the direction that we need to move forward on telehealth, and this was really an unexpected barrier. And so part of this, we had contracted with the Telehealth Alliance of Oregon to help build the assessment and participate in the pilots to refine this process. And unfortunately, the assistance that we received was inconsistent. And really, it came to light that creating an assessment is a pretty skilled process. And just because you have subject matter expertise doesn't necessarily mean that your skill set is building assessments. So our final steps and next steps, are going to be to finalize our two pilot hospital reports and to get those out. We're sending those out tomorrow, actually. And then next week, we'll be soliciting the rest of the critical access hospitals to see if they are interested in participating in the assessment. And based on their interest, we'll evaluate our project and see if any changes need to be made. If any of you guys are interested in the final report, we are more than happy to share a de-identified version with you all. And that's all I've got.
Great. Thank you, Meredith Rose. Troy,
Thank you.
Chris, may we turn this over to you now.
Hi, everyone. Good afternoon. I'm John Packham. I'm director of the Nevada Flex program, and I'm going to basically introduce start off our presentation, but turn it over to Chris Marchand, who is our Director of Project Echo Nevada, and Troy Jorgensen, who is the Program Coordinator for our state's version of Echo. And this all started 5 years ago. It's hard to believe kind of the progress and where we are now, considering that we're relatively new at this endeavor. But Chris and Troy are going to walk you through our program, our accomplishments, our challenges, which we kind of see across even the best and brightest of ECHO programs like New Mexico, and kind of what we heard a little bit about with Hawaii and Oregon. So with that, I'm going to turn it over to Chris and Troy.
Well, thank you very much, Dr. Packham. This is Chris Marchand. I am the Director of Project Echo Nevada. So going over the program description here, we launched in 2012, actually started all of the scouting and pre-launch visits to New Mexico in late 2010 and carried those through in 2011. We were the fourth ECHO in existence, New Mexico, University of Washington, Chicago, and then the University of Nevada. So even though we're only 5 years old, currently we have 20 active ECHO clinics, which is pretty impressive when you think everybody always starts from one. 15 of them are focused on regular disease areas that are open to the public, but we also have 5 additional ECHO clinics that are closed groups, professional development for mental health practitioners in Nevada. The state mental health department actually contracts us to do those groups with, I think the sole purpose of them when they were first started was to retain rural behavioral health providers out there. It's been highly successful, and we're really happy to have that. As far as our program size, we have 2 full-time employees, 1.0 FTE, and then 6 additional part-time employees they serve in different capacities, ranging from finance to continuing medical education and so forth. And our specialist staff is 27 multidiscipline subspecialists or support staff. So for the program goals, I'd say that basically every ECHO program across the border, they're going to have generally the same goals. We want to connect primary care providers to subspecialists, and you want to be able to increase the knowledge base of those primary care providers so that, A, they're able to deliver higher quality patient care in those medically underserved and rural areas. But also, there's a whole competency within this targeted towards job satisfaction for these providers. Scott mentioned earlier reducing provider burnout. That's a big deal when you talk about these isolated rural areas. An increase in professional satisfaction, reduction in professional isolation, and really trying to reduce burnout, because ultimately those are the most difficult areas to recruit providers to. And then also ensuring that we keep rural providers up to date on all of the current best practices and innovations. Not just that, but keeping them up to date on the policies that are taking place. You're talking some of these rural providers are multiple hours and multiple hundreds of miles away from an urban center, and they're not always kept up to date on the most recent laws. And recently with the opioid crisis, there's been a very, very important legislation over the past 2 legislative sessions that impact prescribers directly. And without a clear relay of this information, these prescribers out in the rural areas are kind of left in the dark, and what they tend to do is say, well, I'm just not going to prescribe opiates at all, and we know that's not really a solution. So we make sure that they're up to speed on all of the legislative updates, and that we serve as a support system for them to be able to rely on, to be able to ask questions and stay up to date, and be able to have the confidence to treat some of these patients, these rural patients, locally and help keep that money in the local economy.
So this is Troy. I'm going to talk a little bit about our key achievements and outcomes so far this year. So we've launched 5 new clinics since the start of this year. The first is the pain management clinic. Most of our clinics only run once a month, but through funding through the opioid state targeted response grant as part of the Cures Act, we were able to start a second meeting of that pain management clinic, and that STR funding also helped start the medication assisted treatment clinic, which we run with local team here from Federally Qualified Health Center. And then just in October, we launched 3 new clinics, and that was the pediatric endocrinology clinic, cardiology, which we run with cardiologists from a local hospital here and a nurse practitioner as well, and then the school-based mental health clinic, which we're using to connect rural school counselors, nurses, and therapists with our multidisciplinary team here to consult on behavioral issues and other developmental issues that happen in the schools. And then some of our outcomes that we've seen so far this year is large increase in new participants. So we've seen 254 new participants so far this year. That's compared to just 178 new participants from 2016 during the same time period. So that's a 60% increase since last year. 41 of those new participants were from critical access hospitals, and 198 were from non-critical access hospitals, as well as we've seen 35 new spoke sites. Those include the schools, the rural schools that I've mentioned started joining the school-based mental health clinic. And then another outcome we've seen is the utilization of our antibiotic stewardship echo clinic. So we have 98 critical access hospital participants, and 10 out of the 13 critical access hospitals throughout the state participate in that echo clinic. So this is a picture from our new cardiology echo clinic. On your right, you'll see Dr. Ivan Anderson, who's the cardiologist from the local hospital Renown that we're partnering with to run this clinic. And it had a really great launch. I think we had around 15 participants, and we're just having our next meeting or next session next week.
So I think this is where the rubber meets the road for every echo program out there, because challenge and barriers is the thing that keeps us up at night, and it feels like we'll never get past some of them. I know that some of these barriers and challenges that I'm going to discuss are not unique to our program, but they are prevalent for us. So one of the biggest things, and every critical access hospital experiences the same thing, is that the time allowed for providers to actually participate in echo clinics can sometimes be limited to non-existent depending on the support of the administrator. And when our program has 20 echo clinics or 15 really, that one of their providers or their group of providers that have a choice to participate in, you can pretty much bet that we're not going to get somebody from a facility to participate in every single one of our clinics. So we find that there's some that are more popular than others, but we also find that having so many clinics hasn't really been detrimental to our overall participation, and people still end up joining us. So participation's fairly consistent across the board. But when you're talking about a critical access hospital with provider shortages, that's absolutely a challenge, is telling them or convincing them that the product you're offering is valuable enough for them to take that hour or hour plus out of clinic in order to participate. Funding. Now, while the flex funding is absolutely helpful, and it does help provide some FTE support for our coordinator to be able to coordinate between critical access hospitals, the FLEX program, and Project Echo Nevada. More stable funding. We need stable funding sources, and I think that's a challenge for every ECHO program, that trying to figure out how exactly to keep the lights on long term. In 2015, our state passed legislation that revamped the reimbursement model for telemedicine. They called it a telehealth bill, but when you look at it pretty clearly, there was no mechanism in place that accounted for reimbursing for echo. So that's something that we're currently advocating for, but the next best thing for us is to approach Medicaid for funding. That's a pretty common strategy amongst ECHO programs, and it seems to be a model that we just need to figure out, since each state's unique, how to make it work. But there's several states that have ECHO programs that are working on that as well. Travel time from our base here in Reno to the different critical access hospitals and participating sites around the state, it's several hours to most facilities. And when you have a program staff of 2 full-time people and a handful of part-time people, it's just not feasible to have an in-person presence out in those rural areas as frequently as we'd like to. Community awareness and understanding about the program, we've gotten a lot more brand recognition over the last year and a half or so, which has helped sell, administrators and providers on participating in our program, but we still struggle with it. We're always looking for new ways to promote our program. And then obviously staffing the ECHO Hub team. Yeah, some of it is funding related, and then some of it is just finding the right team members. When you have a small team, you have to rely on recruiting the best people possible.
All right, this is John again. I just wanted to mention that I think our successes and accomplishments are a product of partnerships, many of which have kind of gone back to the early days of our state office and flex programs over the last couple of decades. And I think they're also a product of the fact that we're being university-based, we're able to tap into expertise and resources and partners at both our School of Medicine and School of Public Health, actually our School of Nursing as well. Identified some of those partners on this particular slide here. They also include Nevada Rural Hospital Partners. That's our state's Rural Hospital Association, and their 13 member hospitals are the 13 critical access hospitals and 13 SHIP hospitals in Nevada. So that makes that work easier with those hospitals and their provider-based rural health clinics. I'd also want to say that I think that ECHO builds on and has helped nurture a good relationship with the state of Nevada, kind of most recently illustrated by the work that we're doing as a subcontractor to their SAMHSA opioid grant. Just wanted to add that the essential partnerships include some newbies. I think the ECHO has resulted in a closer level of work than has kind of been the history of our office with federally qualified health centers, not just in rural areas of the state, but as well as urban areas. Community Health Alliance and Northern Nevada Hopes are FQHCs here in Washoe County. And finally, we just round that list out by saying that essential partners would also include our state's QIO, which is Health Insight, and relatively new public health training center based here in Reno in our School of Public Health.
So the facilitators for implementation, one advantage that we had was that there were relationships that had been pre-established for decades in our Office of Rural Health and Flex program, that when we decided to launch the ECHO program here in Nevada, we had a whole bunch of pre-existing relationships, really strong strategic relationships that we were able to leverage within our organizational structure to help us really get off the ground. That was instrumental in making sure that we were successful in the early days. John already mentioned Nevada Rural Hospital Partners. Additional work groups that they help with, and even still today, antibiotic stewardship in our behavioral health and primary care, they rally the troops, if you will, and they go out and they make sure that people are aware of what we're offering and drum up the participation when it seems like the interest might be waning a little bit. The Nevada Office of Rural Health, we work with them quite a bit, especially on the front of the Health Service Corps. Recently included participation in ECHO as part of the loan repayment program contract. So when providers actually come out to do that, participating in Project Echo ensures that they don't get burnt out and that they have a support network in place. The AHEX workforce and professional development programs, we often partner with them in terms of workforce development programs and also promotional events. One of the things that I would say we're very fortunate of is that in our community, even though Nevada, when you look at the whatever medical specialty per 100,000 population, we're at the bottom of the list on most of them. Even with that being said, we don't have a shortage of people who are interested in sharing their clinical expertise with these rural and medically underserved providers because they understand kind of where the state of the healthcare system's at right now. So we have a wealth of community specialists that are currently coming into the fold. One of the biggest things lately, I think 2014 is when we finally transitioned to the video conference system Zoom. That was a huge breakthrough for Project Echo across the board around the world because before we all had to use the Polycom systems, and I know that people here remember Polycom. The Zoom video conferencing system is a web-based system that just works. It works well, and it works on virtually any device that has an internet connection and a camera and a microphone, which, even your cell phone nowadays will do that just fine. So switching over to that video conferencing system has been a godsend in making, because that used to be a major barrier to recruitment of participants in our program. They would get frustrated with the technology and wouldn't be willing to work through the bugs. Now all they have to do is click a link and it fires it up right for them. It's pretty incredible. We've developed champions at these sites, and that's part of having a small program, leveraging what resources we have. When we have a limited number of people in our program, we have to be able to make each call count and count for extra points, in the process. Recently, with our brand recognition, we've actually been able to piggyback with other professional organizations to send out our newsletters if we have information that we'd like to get out to a broader audience, such as the Nevada Board of Medical Examiners or the Medical Association or any of the other licensure boards. We have multiple partners that all we have to do is send them a pre-drafted message ready to go out, and they forward it out to their membership, and we see huge spikes in our website traffic almost immediately afterwards. So it's been a really important development over the last year, maybe.
Yeah, I think we want to just close the discussion by saying that throughout its 5-year history, our ECHO program has been closely connected with Flex. In kind of the early days, Flex helped underwrite some of the needs assessment activity and a little bit of FTE support for Chris, then later Troy. But more importantly, I think our Flex program is now kind of the beneficiary of what we've established. And kind of the two biggies right now are the antimicrobial stewardship activities, as well as the opioid and pain management related clinics that touch every one of our critical access hospitals and rural health clinics in the state. So I think that ECHO is closely integrated, if not seamless, with what we're doing with Flex. Here is our contact information. I think one of the things we always like to emphasize in any discussion of Nevada ECHO is that we've been kind of the beneficiaries of those who've gone before us, in particular Dr. Aurora and the folks in New Mexico. So I always kind of put it out there to a group like this that I hope you guys, anyone on this call or webinar, can turn to us till we don't have to reinvent the wheel as ECHO expands across other states. Really encourage you to call either Chris or Troy, who work on ECHO literally on a daily basis in their jobs. And I believe that's it for us.
For Nevada and Hawaii, are you, especially Nevada, because John, you mentioned being university affiliated has really helped. Do you see, I don't know how your university works. Is it an independent academic institution, and so therefore it doesn't create any conflicts with health system work?
Oh, I think the conflicts with health system work is inevitable. and so, but I would say that I think what's happened in Nevada is that we've kind of literally opened a new public medical school in Las Vegas, and so the hospitals and facilities down south are kind of gravitating towards UNLV, the new School of Medicine in Las Vegas, and that's left us in kind of a good position to where we work the largest tertiary facility here in Reno. There's some frosty relationships between that system and some of our hospitals, but I think we're in some ways we're almost kind of the broker, the kind of the neutral person in that. We've made that work so far.
So do any of the hospitals that are frosty towards the university, do they participate in the echoes?
Yes, I would say they do, yeah.
Okay, great.
Yeah, and we've got a couple of system hospitals that don't work as closely with us because they, can lean on the resources of the mothership. We've got a community health system hospital and then one that's connected with one of the systems, for-profit systems in Las Vegas. But still, I think, the work we're doing in pain management and opioid abuse prevention, we're starting to see even those that we haven't worked as closely with in previous clinics already kind of tapping into these newer clinics.
From an Oregon perspective, it feels like there's a little bit of a provider saturation around Project Echo, in that the same providers seem to be the ones on the list, and they seem a little burnt out on Echo and less likely to participate in new Echo hubs. And I was just wondering if anybody else has seen the same thing. But it sounds like you're having a different experience, John.
Well, I think Chris could probably speak to that. I think there is a little bit of provider saturation, as I understand it. But that just comes with the territory. I think we're pulling providers out of patient care for an hour, and that's always going to be a hurdle.
This is Chris. We absolutely have seen that type of saturation, and with the total number of clinics that we offer, that's become a concern more often than not when we try to decide what's our new clinic and is there really going to be a demand for it. Part of the way to combat that is to actually look at new areas to recruit participants from. There's quite a bit of untapped provider participation potential out there, so we're always trying to scheme some new plan for that. One of the other things that we've been working on, too, is developing clinics that address an entirely different provider type. That example is our school-based behavioral health. Those are all school social workers and psychologists and teachers and counselors.
Yeah, that's really interesting.
So, John or Chris or Troy, one of the things that I've heard in some of the echoes, and I haven't quite experienced it here yet, but I've heard that in some of the echoes that once people get their CMEs for the year, they sort of drop off, and then they come back at the beginning of the next time they need more CMEs. Are you seeing any pattern like that?
No, not in Nevada. CME isn't the carrot anymore. It was when we first started, but CME is so easy to get a hold of. People are interested in some of the stuff that we offer for ethics credits, and so you'll see a spike in participation right around that licensure deadline. So I think that's like April, May, and June. People that attend Echo clinics, the CME is almost an afterthought. No, we see fairly consistent. The biggest thing that affects our participation is holidays and school schedules.
I'm intrigued by the private sessions you're doing for behavioral health providers. Can you fill us in a little bit on what the sort of content is might be for those programs?
Sure. So we have a rural mental health PACE consultation clinic. So that is designed. Our psychologist, who's our mental health director for Project Echo, has kind of an open session that people can bring their extremely difficult cases to bounce ideas off of and get recommendations. And again, these are providers that are out in the remotest areas of Nevada, so their support structure isn't very strong. So they can log on to Zoom, get these case consultations, and be able to take care of those patients with a lot better quality of care. Mental health professional development groups. One of them is for early career professionals who, just recently finished their internships or within the first couple of years of their career. And then we also have a late career professional development group, and obviously the career challenges for those two types of groups are quite different. So we keep them separate, but also the late career people generally tend to be the early career people's bosses. You don't want to complain about your bosses in an open forum with them. And those are really, it's a closed session. They develop as a group, and a lot of times they end up contacting each other between the clinic sessions to bounce ideas off of each other, and it's really grown to be a community inside and outside of the clinic experience. So those two groups have been incredibly successful. 80% of the participants from those groups when they were originally started back in 2012 or 13 are still with that provider today, which is incredible.
Wow.
The other mental health group that's a closed session is a psychology internship supervision group. We just recently, a few years ago, started doing psychology internships in Nevada as a way to help grow the population of psychologists here. And so we've had a couple of iterations of these psychologists, and we use ECHO as part of the 1-year internship supervision process. Our behavioral health director, his role is to help guide those interns through the internship process because it's super strenuous and difficult and stressful. So he helps them get through that, but also he's kind of the intermediary between the interns and their actual preceptors. So if there seems to be a system problem that just absolutely has to be addressed, he'll find a lot of that stuff out during their weekly sessions, and he can address it, or he can bring it up to leadership at the state so that we don't lose interns over a system issue.
Well, that's helpful. Thank you.
Meredith or Rose, this is Andy Coburn at USM. My question really is about the fundamental value that you see in the assessment and whether or not you think it has value for other states, whether there's enough whether you systematized it enough to potentially export it to other states.
Andy, this is Meredith. There's some mixed feelings. So, the two hospitals we piloted it with. So, number one, we don't have a full kind of group of hospital participants to be able to answer this question well. But the two we piloted it with are very small independent critical access hospitals. One of the limitations there is frankly the number of providers and leaders responding to the survey. On the other hand, it's pretty apparent that actually people aren't aligned even in an organization that small. And usually there are a couple providers that are the key voices at a hospital that kind of put their opinions out, especially on things like Project ECHO. It is giving a more well-rounded look at what do providers across, the whole facility, and they get to select, Andy, which levels of providers they want to include in the assessment. So, for example, there's been some discussion about should MAs be included, not necessarily the same level of provider, but pretty instrumental to workflows around telehealth and implementing Project ECHO potentially. I think there's room. I think we're hopeful is the way I would put it. That we want to see what happens when it goes out to other critical access hospitals. It'll go out. It's gone out to 2 pilot assessments. It goes out to 23 other critical access hospitals next week. And depending on what we get back and the level of interest and participation, I think then we could talk about it. I personally think there's a lot of areas in which we really need some telehealth expertise to be able to develop this assessment process in a way that's going to be meaningful and could be shared across other states. But I think some of the basics could be helpful as a starting platform.
Well, great. Thank you, everyone. Questions for the good of the order?
Hi, this is Yvonne. Sorry, I dropped off for a second, but I was wondering, so I'm sorry if you covered this already, but I was wondering, in regards to Project ECHO, have you guys been able to collaborate with the Hospital Improvement Innovations Network, the HINs? Because I know they also have a Project ECHO for antibiotic stewardship programs with about 24 quick access hospitals just starting up.
I would say in Nevada, not formally or officially, but what we're doing is clearly in sync with the goals of our our QIO and our HIN project here.
Yeah, not directly with the HIN here yet. So
I was going to ask if there are any other questions. If not, thank you all for your time. And it was very helpful. I think informative for me, and it's great to hear more about what you're all doing. We will do these again in the future. So thank you very much.
Thank you. Thank you.
From Nevada.
Thank you.
Bye-bye.